Okay, folks, good evening to SUPERPoints Master Class in Cardiovascular System. In today's class, I would like to discuss some super questions. And the SUPERPoints is always about what is most important for your exam. So let's go directly into the questions. First question: a 59-year-old man presents for an annual health examination. He denies dyspnea, orthopnea, paroxysmal nocturnal dyspnea, or lower extremity edema. His past medical history is notable only for well-controlled hypertension. Physical examination reveals a grade 2 by 6 holosystolic murmur, best heard at the apex and radiating to the axilla. An echocardiogram demonstrates mild left ventricular remodeling with preserved functional status. According to the American College of Cardiology, American Heart Association classification, which of the following best describes this patient's stage of heart failure? All right, folks, we have 4 choices. Please go ahead and choose your best answer. So the correct answer here is 2. All right, this is stage B, heart failure. Okay, stage B, heart failure. The American College of Cardiology, American Heart Association classification of heart failure is widely used staging system that categorizes patients based on risk factors, presence of structural heart disease, and clinical symptoms. Unlike the New York Heart Association classification, that is functional classification, which focuses on symptom severity and functional limitation, ACC-AHA system emphasizes the progressive nature of heart failure and early identification, prevention, and management. It consists of 4 stages, the stages A and B representing pre-symptomatic disease and stages C and D representing symptomatic heart failure. This framework is essential for clinical decision making and a high-yield concept for examinations, particularly in distinguishing asymptomatic structural heart disease from overt heart failure. So, you all know about New York Heart Association classification of heart failure, that in class 1 we have people who are completely normal, right? No symptoms. Then you have mild symptoms. Then you have moderate symptoms. Then you have severe symptoms. So it's all about functional. But in this classification, we also have structural heart disease. That's a very important concept here. So, patients with stage B heart failure have structural disease but no current or prior symptoms of heart failure. So, they may have prior myocardial infarction, they may have mitral regurgitation, they may have left ventricular hypertrophy, reduced ejection fraction without symptoms, elevated cardiac biomarkers like BNP or troponin. Okay. So, in this patient, we have grade 2 by 6 apical holosystolic murmur radiating to the axilla is clinically significant and consistent with mitral regurgitation. So, this patient has a form of structural heart disease that places him at risk for future symptomatic heart failure, and he is asymptomatic. That's why he is stage B. All right. So, stage A is risk factors only. There is no structural heart disease. In stage B, they have structural heart disease but no symptoms. In stage C, they have structural heart disease plus symptoms. In stage 4, they have severe disease. It's an end stage disease. So, ACC-AHA staging focuses on disease progression, okay, and NYHA classification reflects current symptom burden. So, if you see this patient, for example, let us say this patient has mitral regurgitation, right? So if this patient has mitral regurgitation, they have left atrial pressure getting high, and then there is this backflow into the lungs, and there is a pulmonary edema here, and then there is pulmonary artery pressure going up, then that is being transferred to the pulmonary artery. So then being transferred to the right atrium and right ventricle. So once mitral regurgitation becomes severe, you see that backflow into the lungs and the pulmonary edema is happening. So even though this patient with mitral regurgitation is asymptomatic at this time, he could go into pulmonary edema as the disease progresses and heart failure gets worse. All right. So you see the importance of this classification. Okay. So how do you remember this? What is the super mnemonic? I use this one. A is at risk, B is built, C is for complaints, D is for decline. All right. So A, B, C, D. A means at risk. A means at risk. They have only risk factors. No structural problem, no symptoms. B means built heart disease. That means like they have a structural disease but no symptoms. Then C means complaints. Remember that. Stage C means complaints. That means patient will tell you, doctor, I can't sleep. I can't walk more than a few blocks. I have shortness of breath. I have fatigue. I have chest pain. So he will tell you the symptoms. That is stage C. And then stage 4 is decline. That is advanced refractory heart failure. So progression from risk to structure to symptoms to end stage. That is what we are saying here. Now let us see the incorrect answers. Why is not stage A? This is not stage A because in stage A, patient is at risk, all right, and he has without structural heart disease. This patient already has evidence of structural disease, right? He has mitral regurgitation, that is a structural heart disease. So he is not stage A heart failure. Then stage C. In stage C, remember, C is for complaints. This patient has no complaints. That's why he is not stage C. Stage D. Stage D is much worse. He has advanced refractory heart failure requiring specialized interventions like transplant or left ventricular assistant device. So this patient is structurally asymptomatic. Okay. So in stage D, he is very severe. He has severe symptoms. He has structural heart disease. So this patient is not stage D. He is stage B. So what is the SUPER formula? SUPER formula is when you see someone is about important points. Okay, this patient is asymptomatic, structural heart disease, and this helps to identify high-risk patients who preventive therapies to delay progression to symptomatic heart failure. It is functionally equivalent to NYHA class 1. All right, that is stage B heart failure. So stage B heart failure is he has risk factors, he has structural heart disease, but he has no symptoms. How does that help? It helps a lot. He is asymptomatic. For example, he has mitral regurgitation. You can fix mitral regurgitation. If he has mitral stenosis, you can fix mitral stenosis. If he has aortic stenosis, aortic regurgitation, whatever valvular problem he has, or whatever coronary artery disease he has, you still have time to fix it. All right, so that is the importance of stage B heart failure. The SUPER point is something you must put to memory. The SUPER point is ACC, AHA, heart Stage B heart failure is defined by asymptomatic structural heart disease requiring early intervention to prevent symptomatic progression. All right, folks, that's about stage B heart disease. Very, very important. All right, every doctor needs to know about these classifications because they are frequently asked on your examination. Let us go to the next question. A 65-year-old man with chronic systolic heart failure, left ventricular ejection fraction 35%, moderate obstructive sleep apnea is evaluated in a clinic. He reports excessive daytime sleepiness and poor sleep quality. His primary care physician recommends continuous positive airway pressure therapy. The patient asks whether CPAP will improve his long-term heart failure outcomes. Which of the following best describes the effect of CPAP therapy in patients with heart failure and obstructive sleep apnea? So, you got a patient with a heart failure and obstructive sleep apnea, and he has questions about CPAP. What is the effect of CPAP therapy on my heart failure and obstructive sleep apnea? So, choose one of the best answers from these four choices. So, the best here is number 3. All right. So, why? Let us discuss this very, very important clinical disorders. CPAP improves sleep-related symptoms but has not been shown to improve long-term heart failure outcomes. Okay. So, if you look at this topic, first of all, always think about topic. What is the topic? The topic here is the role of continuous positive airway pressure therapy in heart failure with obstructive sleep apnea. What is obstructive sleep apnea? Obstructive sleep apnea is a common and often unrecognized contributor to cardiovascular disease, including heart failure. CPAP therapy effectively treats OSA by preventing upper airway collapse during sleep and has been shown to improve fatigue, daytime sleepiness, sleep quality, to improve short-term cardiovascular parameters like blood pressure and sympathetic tone. However, despite early observational studies and short-term trials suggesting reductions in cardiovascular events, large randomized controlled trials have not demonstrated improvements in patient-oriented outcomes. All right, that's what you need to learn from this question. So, CPAP is good. All right, it makes you feel better the next day because the oxygenation happened well, right? Next day you are so happy and doing good. But in the long-term mortality in this patient with heart failure is not going to make him live longer. All right. So that's very important. It may help in the short term, like improving the sympathetic tone, improving the blood pressure, those things. But in the long term, like long-term mortality, heart failure hospitalizations, CPAP has not been shown to be beneficial. So, therefore, CPAP is primarily used in heart failure patients with OSA to improve sleep-related symptoms, but not to definitely improve long-term heart failure prognosis. Take-home patient points. CPAP improves sleep apnea symptoms and fatigue. No proven benefit on long-term heart failure outcomes. That is the point you should remember from this question. No proven benefit on long-term heart failure outcomes. Treat OSA for symptom relief, not mortality reduction. Sleep apnea, if a patient has sleep apnea, treat with CPAP. Encourage CPAP, but tell them the truth. Sir, this is about sleep. It's not about survival. So that is the supermnemonic here. Supermnemonic is CPAP helps us sleep, not survival. All right, remember that. That is the mnemonic. CPAP helps sleep, not survival. So it improves sleep apnea symptoms, fatigue and daytime sleepiness, but no proven improvement in long-term mortality or heart failure hospitalizations. Coming to incorrect answers. Why not number 1? Number 1 says CPAP significantly reduces long-term mortality and heart failure hospitalizations. That is incorrect, right? I told you. Although early studies suggest benefit, long-term randomized trials have not shown reductions in mortality and heart failure hospitalizations. And choice 2, CPAP worsens cardiac outcomes due to increased intrathoracic pressure. That is also not correct. CPAP actually may transiently affect preload, but overall it does not worsen heart failure outcomes. It's a safe thing. So it won't make it worse than it is. Then choice 4, why is choice 4 is incorrect? CPAP is contraindicated in patients with reduced ejection fraction. That is also incorrect because CPAP is not contraindicated. All right, CPAP is not contraindicated. You can use it. In fact, it is good for short-term benefits, for non-cardiac mortality related factors, like as I said, if you want to improve blood pressure, even the risk of dementia will go down in CPAP use because the brain oxygenation improves with the CPAP. All right. So what is the super formula? Super formula is about identifying the keywords and going to the correct answer. Okay. So CPAP, it prevents upper airway collapse during sleep. It improves sleep quality, fatigue, daytime sleepiness. It improves short-term cardiovascular parameters. It decreases sympathetic tone, decreases BP. No proven reduction in long-term mortality. No proven reduction in heart failure or hospitalization. So CPAP therapy in heart failure with obstructive sleep apnea. What is the super point? If there is one sentence you must remember from this whole discussion, what is it? That is the super point. In patients with heart failure and obstructive sleep apnea, CPAP improves sleep-related symptoms and fatigue, but does not improve long-term mortality or heart failure hospitalizations. All right, folks, I gave you some references here. You can go through those references. They are beautiful articles from NEJM and JAMA network and respiratory research. Okay, so you can explore more on that topic by following those links. You can see. Next, let us go to this question. Very, very interesting question. A 48-year-old woman with hypercholesterolemia is started on high-intensity statin therapy. 2 weeks later, she reports diffuse bilateral thigh and calf muscle aches without weakness. Physical examination is unremarkable. Laboratory testing shows a creatine kinase level within normal limits and normal renal function. Which of the following is the most appropriate statement regarding her condition and management? So you have a 48-year-old woman, hypercholesterolemia, and she started on high-intensity statin therapy. Then 2 weeks later, she is reporting diffuse bilateral thigh and calf muscles pain. All right. So what do? Physical examination is unremarkable. Creatine kinase is within normal limits. Normal renal function. So what is the approach? What is the next best step? Choose one of the 4 options given. So the correct answer here is option 3. All right, option 3 is the correct answer. And let us see why that is so. So, again, what is the topic? Always think about, like, it takes like a couple of seconds to think about the topic. Okay, topic here is statin associated muscle symptoms. And why I am saying that you should think about the topic? It's like in everything. Research has shown that people who think about the context will go to very good decisions in life. All right. What are you talking about? Where are you? All right. It's about orientation to time, place, and person. First, you need to be oriented. The same goes in these examinations. You first identify what you are talking, what is the questioner, what is the examiner is talking about. He is talking about statin associated muscle symptoms. What do you do when a patient comes to you and states about these things, muscle symptoms, after you start him with a statin? All right, statins are the cornerstone of therapy for hyperlipidemia and cardiovascular risk reduction, but their use may be limited by statin associated muscle symptoms, SAMS. The most commonly reported adverse effect of statin therapy. These muscle-related symptoms range from benign myalgias without creatine kinase elevation to rare but serious complications such as myonecrosis and rhabdomyolysis. Although muscle symptoms occur in approximately 5 to 10% of patients, true statin-induced severe muscle injury is uncommon. Proper recognition, classification, and management of SAMS, including temporary statin discontinuation and rechallenge with alternate statins, dose modification are essential to ensure continued lipid control while minimizing adverse effects. This topic is a high yield for examination, emphasizing evidence-based management and avoidance of unnecessary statin discontinuation. This patient has statin-associated myalgia, the most common form of statin-related muscle symptoms. All right, before you go further, understand some key definitions. Myalgia means muscle pain without CK elevation. Myopathy means muscle weakness plus pain. Myonecrosis, in myonecrosis, creatine kinase elevated like 3 to 10 times more than the upper limit of normal. In rhabdomyolysis, you see myonecrosis plus renal failure. All right. So, appropriate management in patients with myalgias or normal CK or CK less than 10% of upper limit, temporarily discontinue the statin. All right. So, a patient like this who just have some muscle pains, temporarily discontinue. All right. Stop a few weeks and then restart with a new statin. All right. Once the symptoms resolve and CK normalizes, try a different statin, and most patients ultimately tolerate statin therapy. Alternate strategies include dose reduction, alternative dosing with long-acting statins. So, we try to keep people on statins. Why? Because they are cardioprotective. All right. They not only decrease your cholesterol level, they also have anti-inflammatory properties. Okay. Atherosclerosis is inflammatory process. So, how can you decrease that inflammation? You have to use a statin. That's why you don't give up when the patient says, I got some muscle pains. Okay. So, there is 2-acetyl-CoA becoming acetyl-CoA, then HMG-CoA, and statins are HMG-CoA reductase inhibitors. Okay. And so, they are HMG-CoA and what happens because of the cholesterol going down, this uptake, increased transcription of LDL receptor, there is increased LDL are transported to hepatocyte membrane, increased clearance of circulating LDL particles, and then there is a plaque stabilization. You see, there is plaque stabilization. That's a great blessing. It stabilizes the plaque. And what is the final outcome? The final outcome is significant reduction in serum LDL-C and cardiovascular mortality. So, they improve plaque stabilization and they significantly reduce LDL and cardiovascular mortality. So, indications are primary and secondary prevention of AS, CVD and hypercholesterolemia. You need to, in general, you need to monitor AST and ALT activity. And contraindications are active liver disease and pregnancy. And adverse effects, myalgia, that is the most common. Then there is a hepatic transaminase elevations. Then there is a modest diabetes risk. Remember that point also, because that can be another question. What is the adverse effect of statins? One of the adverse effect is they have a modest diabetes risk. And then there is rarely, you are also seeing rhabdomyolysis. All right, remember myonecrosis plus renal failure is rhabdomyolysis. So the super point here is statins are first-line LDL lowering drugs that reduce cardiovascular morbidity and mortality. Although they carry a modest diabetes risk, their benefits in preventing ASCVD far outweigh this concern. Now, what is the super mnemonic? How do you remember? All right, SAMS, legs ache, CK decides. Remember that one thing. In SAMS, legs ache, but CK decides. Legs ache, that is the most common complaint, diffuse bilateral leg muscle pain. And CK decides, like check the CK level, and if it is normal, if it is less than 10 times upper limit, then stop statin briefly and re-challenge possible. Then if it is more than 10 times upper normal, then renal failure, then there is rhabdomyolysis happening, which is rare. All right, folks. And why not other answers? Let us say permanent discontinuation, that is option 1, that is incorrect. All right. Most patients with statin associated myalgias can tolerate statin or lower adjusted dosing. Then there is number 2, coenzyme Q10 supplementation. So coenzyme Q10 is not recommended, okay, it's not recommended for this problem. Then number 4 says routine CK and liver enzyme monitoring. That is also incorrect because routine monitoring is not indicated. You don't have to routinely, like checking every 2 months, 3 months. You don't have to do that in asymptomatic patients. Now, super formula is about looking at a question and finding the keywords and going to the answer in a few seconds. A patient reports diffuse bilateral thigh or calf muscle aches. He has been on statin therapy. He has normal or elevated creatine kinase level. You temporarily discontinue the statin. Once symptoms are resolved, re-challenge with a different statin. All right? And avoid unnecessary permanent discontinuation of a cardioprotective medication. So we are talking about statin associated myalgia. All right. Then what is the super point? What is the most important point you must remember from this whole discussion? Statin associated muscle symptoms most commonly present as diffuse bilateral leg myalgias with normal CK levels, and most patients can safely tolerate a different statin after temporary discontinuation. Right? Most patients can safely tolerate a different statin after temporary discontinuation. So remember this concept very, because statins are among the most commonly prescribed medications, and as cardiovascular disorders go higher and higher all over the world, all right, everybody has to prescribe these medications. everybody will have patients who come to them and say, doctor, I have these muscle aches, what should I do? So you should know what you should do at that time. All right, folks, that's a very interesting question. Let's go to the next one. A 60-year-old woman with heart failure, with reduced ejection fraction and long-standing hypertension has been treated with enalapril, a beta blocker and a loop diuretic. She presents to the emergency department with a severe tongue and lip swelling requiring airway protection, and enalapril is discontinued. Her blood pressure remains elevated despite optimization of other heart failure therapies. Which of the following medication regimens is most appropriate next step to manage her blood pressure and heart failure? All right, folks. So there are 4 options given, and choose the best one you think is the right answer. All right, folks, the best answer here is number 4, hydralazine and isosorbide dinitrate. And let us discuss this question, okay? First of all, as I said, what is the topic? The topic here is management of heart failure with reduced ejection fraction in patients intolerant to ACE inhibitors. So you have a patient with heart failure and reduced ejection fraction, and he is also intolerant to ACE inhibitors. What should you do in that scenario? So angiotensin converting enzyme inhibitors are a cornerstone of therapy for heart failure with reduced ejection fraction due to their robust mortality and morbidity benefits. However, serious adverse effects such as ACE inhibitor-induced angioedema necessitate permanent discontinuation of these agents. In such patients, alternative evidence-based therapies must be selected carefully, as angiotensin receptor blockers may also pose a risk of recurrent angioedema and generally avoided without specialist consultation. The combination of hydralazine and nitrates provides a proven mortality benefit in HF-REF and serves as the preferred substitute when renin-angiotensin-aldosterone system blockade is contraindicated. Understanding appropriate medication selection in this setting is a high-yield concept for examinations, integrating pharmacology, contraindications, and guideline-directed medical therapy. So, in this question, they are testing your knowledge of pharmacology and also evidence-based medicine and also contraindications. All right. This patient has heart failure with reduced ejection fraction, and he also developed angioedema while taking ACE inhibitors. That's an interesting question on its own right. Angioedema is a common complication of ACE inhibitors. So ACE inhibitors are contraindicated and ARBs should generally be avoided. All right. So a person has angioedema after ACE inhibitors. ARBs are also contraindicated, and some cases, yes, you can ask allergy consultation, and under his guidance or her guidance, you can give ARB and take a chance for a few days. But generally, ARBs are also avoided in these patients. So the best supported alternative with mortality benefit, that is the keyword here, mortality benefit. ACE inhibitors have mortality benefit, ARBs have mortality benefit. Then who has mortality benefit? Hydralazine and nitrates. Studies have shown nitrates and hydralazine have mortality benefit. Okay, hydralazine plus isosorbide dinitrate, they proven to reduce mortality in HF-REF, particularly indicated in patients intolerant of ACE inhibitors or ARBs, patients with contraindications to ROS blockade. They improve preload and afterload without increasing angioedema risk. All right, folks, like any medications, first get a big picture, what different medications are used. Okay, for example, in heart failure, You have positive inotropes like digoxin and digitoxin. There are intravenous positive inotropes like dopamine, dobutamine, epinephrine, norepinephrine. There are beta blockers like metoprolol. There are heart rate reduction agents like ivabradine. There are mineral corticoid receptor antagonists like spironolactone, eplerenone, and finerenone. Then there is diuretics. We have thiazide diuretics like hydrochlorothiazide. Then there are thiazide-like drugs like chlorthalidone, indapamide, metolazone. Then there are loop diuretics like furosemide, torsemide, bumetanide, ethacronic acid. Then there are very, very important ACE inhibitors like lisinopril, captopril, enalapril, ramipril, like that. Then there are ARBs like valsartan, losartan, irbesartan, like that. And they are angiotensin receptor blocker, neprilysin inhibitor, sacubitril and valsartan combination. That's also an important question. And there are intravenous vasodilators like nitroglycerin, sodium nitroprusside. Then there are vasodilators like isosorbide dinitrite, hydralazine. Then there are also PDE3, 4 inhibitors like milrinone, enoximone. And there are combined calcium sensitizer PDE3 inhibitors like levosimendan. All right. So when you have a good idea about different classes, you have to think about which medications have mortality benefit. Okay. And supermnemonic. Supermnemonic is how to remember this. So if you have a patient with heart failure with reduced ejection fraction, no ACE, no ARB, then use HN. No ACE, ARB, use HN. That's a very short form. Just remember that. You can't give ACE inhibitors, you can't give ARBs, but you want to reduce mortality. What do you want to use? Hydrogen and nitrates. All right. So ACE inhibitors contraindicated due to angioedema, hydrogen, nitrates, mortality benefit. Okay. So ACE inhibitors angioedema, avoid ACE inhibitors ARBs, switch to hydrogen and nitrates. Now you might ask me, why not number 1, losartan and carvedilol, ARB. All right. Losartan is a ARB, right? So it is not routinely started in patients who develop severe ACE inhibitor-induced angioedema without allergy specialist input. Why not terazosin and hydroxyzine? This is also incorrect because alpha blockers have no mortality benefit, all right, in heart failure. So in heart failure, alpha blockers do not have any mortality benefit. Why not amlodipine and furosemide? Again, calcium channel blockers do not improve mortality. All right. Amlodipine is a calcium channel blocker, so they do not improve mortality. And then super formula. Super formula is about most important keywords. So a patient with heart failure with reduced ejection fraction develops life-threatening angioedema from an ACE inhibitor. Because angioedema is a class effect concern, both ACE inhibitors and angiotensin receptor blockers are contraindicated in this setting. The regimen of choice, which has proven mortality benefit and does not carry a risk of recurrent angioedema. All right. What is that class? That is hydrogen nitrate therapy. And SUPERPoints. What is the most important thing you must remember from this question is this one. In HF/REF patients with ACE inhibitor induced angioedema, avoid ACE ARB, switch to hydroxyzine plus a nitrate for mortality benefits. All right, folks, this is a very, very interesting question because it asks you about which medication has mortality benefit. All right, let us go to the next one. A 70-year-old man with a history of ischemic cardiomyopathy presents with progressive dyspnea on exertion, orthopnea, bilateral lower extremity edema. Physical examination reveals elevated jugular venous pressure. Echocardiography confirms structural heart disease with reduced ejection fraction. Which of the following abnormalities is most likely to be found in this patient? So, take a few seconds and go for one of the best answers among these 4 options. So, in these 4, the best answer is option 3. Option 3 is the best answer, and I will explain why. In basically, what is the topic? The topic here is laboratory abnormalities in heart failure. That is what he is focusing on. He wants you to know what are the laboratory abnormalities in a patient with heart failure. Heart failure is a systemic disorder that produces characteristic laboratory abnormalities as a consequence of reduced cardiac output, venous congestion, and neurohumoral activation. In patients with structural heart disease and symptomatic heart failure, impaired forward flow, and chronic passive congestion of organs, particularly the liver, lead to biochemical changes such as elevated serum transaminases. Additionally, activation of vasopressin and the renin angiotensin aldosterone system results in dilutional hyponatremia and fluid retention. Recognition of these laboratory patterns is essential for diagnosis, severity assessment, and prognostication in heart failure, and represents a high-yield topic for examinations. So, why elevated serum transaminases? Because there is chronic congestion of liver from right-sided or biventricular heart failure, leads to congestive hepatopathy, results in mild to moderate elevation of AST and ALT, may also elevated bilirubin and alkaline phosphatase in advanced cases. Additionally, heart failure leads to increased vasopressin, water retention, dilutional effects, reduced hepatic perfusion, hepatocellular injury. All right, because ADH goes up, there is water retention, sodium level falls down. That's why patients develop hyponatremia. All right, and remember that earlier diagram I showed. All right, so if you see, for example, if you see there is heart failure here, what happens? This heart failure can cause pulmonary edema. Then increased pulmonary artery pressure can cause more problems in pulmonary artery. Then you can have even right-sided heart failure, and this can go like this pressure can transmit into the liver. So, there is congestive heart failure, there is chronic passive congestion, then there is centrilobular necrosis in liver, then there is a mottled red and tan gross appearance, and this is called nutmeg liver. That's a very interesting question on its own rights. In heart failure, the liver will have this characteristic appearance, nutmeg liver appearance. This is nutmeg. So, this is the exact appearance, nutmeg liver appearance. So, what is happening? There is congestive hepatopathy. So, AST and ALT levels going up. All right. So, how do you remember this? A failing heart, failing liver, and low sodium. Remember that one mnemonic. Failing heart leads to failing liver plus low sodium. Then everything comes up. You can easily answer this question. So, hyponatremia, I told you already that ADH is going up, there is water retention, and that is the problem. So, the incorrect answers, number 1, elevated creatine kinase level seen in acute myocardial injury or rhabdomyolysis, all right, and elevated D-dimer level, it suggests thromboembolism, pulmonary embolism. Heart failure alone does not elevate D-dimer. And why not hypernatremia? Heart failure is associated with hyponatremia. not hypernatremia, right? In heart failure, we have hyponatremia due to excess ADH mediated water retention. So coming to SOPER formula, if the patient has structural heart disease, decreased cardiac output, venous congestion, neurohumoral activation, chronic passive liver congestion, increased AST, ALT, transaminases, increased vasopressin, water retention, hyponatremia, ventricular wall stretch, increased BNP, and that is all you see in heart failure. So what is the SOPER point here? SOPER point is that one most important thing you must remember. So SOPER point here is symptomatic heart failure is associated with elevated serum transaminases from congestive hepatopathy, dilutional hyponatremia from excess ADH, and elevated BNP. All right, folks. So that's a very interesting question. The examiner is testing your knowledge of laboratory abnormalities in heart failure. Let us see the next one. A 52-year-old man presents for a preventive health visit. He has no chest pain or dyspnea. His medical history includes well-controlled hypertension. He does not smoke, does not have diabetes mellitus. His father had a myocardial infarction at age 54. His lipid panel shows borderline elevated LDL cholesterol. His calculated 10-year ASCVD risk is 9%. The patient asked whether a CT coronary artery calcium scan would be useful in deciding whether to start statin therapy. Which of the following is the most appropriate counseling regarding CAC scanning in this patient? So this question is about CT coronary artery calcium scan, all right, CAC scan, and go ahead and choose the most important answer you can think about. So the correct answer here is A, because CAC is used in intermediate ASCVD risk. All right. So for example, a patient is like 45 years old. He says he has no diabetes, he has no symptoms, but he wants to start statin, but you are not sure. There is some uncertainty. Then CAC score would be helpful to you. Let us discuss this very important thing. All right. The topic here is coronary artery calcium scoring and cardiovascular risk assessment. Okay. Coronary artery calcium scoring is non-invasive CT-based imaging modality used to quantify the burden of calcified atherosclerotic plaque in the coronary arteries. It serves as an adjunctive tool in cardiovascular risk stratification, particularly when decisions regarding statin initiation are uncertain. According to American College of Cardiology guidelines, CAC scoring is not recommended for population level screening. So CAC scoring is not for populations. It is only for selected patients. It may be helpful in selected patients. All right. So when CAC scoring is useful, adults 40 to 55 years, intermediate risk. That is the keyword. Intermediate risk. That means like 5 to 20% ASCVD risk. There are no known cardiovascular disease. In other words, if the patient says, I have myocardial infarction history, then you should not use CAC score. The patient has diabetes, then you should not use. All right. Patient should not, like this patient, the patient should not have diabetes. Then there is uncertain decision regarding statin therapy. So in such cases, CAC score is 0, that means low risk, and you can defer. Elevated CAC score, you can initiate statin therapy. So this patient fits the intermediate risk category. all right, intermediate risk category with borderline statin indication, making CAC scanning appropriate, all right. So take home points here is CAC score helps refine statin decisions, best used in intermediate ASCVD risk, not for low risk screening or known CAD, all right. Then CAC score 0, that means low risk. High CAC, statin favored. So how do I remember this? All right. What is the mnemonic? The super mnemonic here is CAC is on Interstate 520 heading towards Statin City or Deferville. So imagine like a highway, Interstate 520. So CAC is on Interstate 520 heading towards Statin City or Deferville, all right. So Interstate 520 here is for patients at intermediate risk, all right. There, when you see that interstate, you can remember intermediate. And 520, Interstate 520, then 520 you can remember 5 to 20%. And heading toward CAC 0, Statin City, all right. If it is more than 0, then start statins. If it is 0, take the exit at Deferville. That means defer therapy. Do not give statins if the CAC score is 0. Another mnemonic is 4 no's for when to use CAC. Use CAC as a tiebreaker in patients with no known cardiovascular disease, no diabetes mellitus, no clear statin indication, no clinical decision after shared decision making. So when you have those 4 no's, CAC can be used. Then incorrect answer, why not number 2? Use in known coronary artery disease. All right, I told you clearly, CAC is not recommended in patients with established coronary artery disease as it does not change management. For example, if you have coronary artery disease, the doctor would start you on statin anyway. You don't have to struggle about all these scores. Then routine screening for all patients over age 40. But first of all, this is not routine screening. It is not recommended due to lack of benefit, radiation exposure, cost effectiveness. Basically, it is a CT scan. You are looking at 4 to 5,000 rupees or dollars, right? So you don't want to waste a lot of money. You don't want to expose patient to radiation. So this is not a general population-wide recommendation. You use this selectively in some patients. Then reserved for post-bypass. So no. Why? Because if you have post-bypass, you already have coronary artery disease. So this is not for coronary artery disease. So no guidelines support CAC use after revascularization. All right, folks. So the SUPER formula here is, it is a non-invasive imaging tool used for cardiovascular risk stratification in heart failure and primary prevention, useful as a decision tool to resolve clinical uncertainty regarding the initiation of statin therapy, especially by detecting and quantifying calcified atherosclerotic plaque burden, age 40 to 55 years. Intermediate, remember interstate 520, so it is intermediate risk and 5 to 20%. No known clinical atherosclerotic cardiovascular disease. I told you, if it is post-CABG or history of myocardial infarction, don't use this. If you have high risk, don't use this. If it is low risk, don't use this. This is only for intermediate risk. And if the patient has diabetes, don't use it because this is only for no diabetes mellitus. And this is not for population screening, not for low risk patients, not for CAD or post revascularization, looking at coronary artery calcium scan. Now, what is the super point? The one point you must remember from this whole discussion is CAC scoring is most useful in asymptomatic adults with an intermediate ASCVD risk to clarify whether statin therapy should be initiated. It is not recommended for routine screening or in patients with known coronary artery disease. All right, folks, that's the important question. And next, let us go to this one. A 31-year-old man presents to the emergency department with substernal chest pain that began shortly after using cocaine and resolved prior to arrival. He appears anxious and diaphoretic. Vital signs show a blood pressure of 165 by 105 mmHg and a heart failure. Heart rate of 122 per minute. In ECG demonstrates deep symmetric T-wave inversions in leads V2 to V4 with a prolonged QTC interval. Cardiac troponins are pending. Which of the following is the most appropriate initial management for this patient? All right, folks, there are 4 choices. Choose the best answer you can think of. So the best answer here is choice 2. Basically, you see, this patient came after cocaine. All right, cocaine. Cocaine is the problem here. Cocaine. This is cocaine-induced heart disease. In cocaine-induced heart disease, you start with benzodiazepines and nitroglycerin. Okay, let us discuss this very interesting question. So the topic we are talking about is cocaine-associated chest pain and acute coronary syndromes. Unfortunately, cocaine use is increasing, whether in India or in the United States or anywhere in the world, frankly. Cocaine use is going up. So it's a well-recognized precipitant of acute chest pain and myocardial ischemia, even in young individuals without traditional cardiovascular risk factors. Cocaine induces myocardial ischemia through multiple mechanisms, including alpha-adrenergic mediated coronary vasospasm, increased endothelin-1, reduced nitric oxide, enhanced chest platelet aggregation, accelerated atherosclerosis with chronic use. Approximately 5% of patients presenting with cocaine-associated chest pain are diagnosed with myocardial infarction. So you say, approximately 5% of cocaine-associated chest pain, they are diagnosed with myocardial infarction. That's a very important point. Initial management depends on the presence of acute intoxication, focuses on reversing sympathetic overactivity and coronary vasoconstriction, recognition of characteristic ECG findings such as Valence syndrome, and understanding appropriate first-line therapy are high-yield concepts for examinations integrating cardiology, pharmacology, toxicology. So it's a fascinating concept. You are dealing with cardiology, pharmacology, and toxicology. So this patient presents with cocaine-associated chest pain and signs of acute intoxication, hypertension, tachycardia, and anxiety. Pathophysiology of cocaine-induced ischemia is alpha-adrenergic mediated coronary vasospasm, increased endothelin-1 and decreased nitric oxide, increased platelet activation and thromboxane 2, accelerated atherosclerosis with chronic use. ECG findings, biphasic or deeply inverted T waves in VT to V4 are characteristic Valence syndrome, which reflects post-ischemic reperfusion injury, often related to critical LAD involvement or severe vasospasm. So if you see cocaine, all right, cocaine, it blocks dopamine reuptake and it blocks norepinephrine reuptake. So what is happening? There is so much norepinephrine here. And it can cause so many problems. Cocaine can increase hypertension, myocardial infarction, aortic dissection, aortic rupture, angina, cardiogenic edema, supraventricular tachycardia, atrial fibrillation, atrial flutter, ventricular tachycardia, ventricular fibrillation, torsades points. You see, cocaine is a mess. All right, basically it's causing everything you study in cardiology. All right, so these wide QRS complexes, they cause wide QRS complexes. Now this question is about the management. The initial management is benzodiazepines. Why? Because they reduce sympathetic stimulation, they improve anxiety, hypertension, tachycardia, and they relieve chest pain. All right, and you also give nitroglycerin because they reverse coronary vasoconstriction, they lower blood pressure, they improve myocardial oxygen therapy. So that combination is the treatment of choice in acutely intoxicated patients. So what is the mnemonic? The super mnemonic is high on coke, benz plus nitro, but no beta. All right, high on coke, benz plus nitro, but no beta. All right, so no beta here means no beta blockers. You use cocaine induced chest pain, benzodiazepines, nitroglycerin. Do not give beta blockers in acute intoxication. When patient has acutely intoxicated, all right, and he is anxious, he is having chest pain, do not give beta blockers like metoprolol, propranolol, that kind of stuff. Give benzodiazepines and nitroglycerin, all right. And valence syndrome. Valence is warning LAD. Biphasic or deeply inverted T waves in V2 to V4, that is valence syndrome, commonly seen in cocaine intoxication. They indicate critical LAD ischemia vasospasm. All right, when you see those things like inverted T waves in V2 to V4, and that's a very critical LAD ischemia vasospasm going on. Here you might ask, what about number 1? Why not aspirin, clopidogrel, heparin? Antiplatelet and anticoagulation therapy may be considered later, but initial management, all right? Here, like it's always important to see what the examiner is asking you. Initial is the key word here, okay? Initial. So he wants you to know what you do at the beginning, all right? Then intravenous metoprolol. I told you, beta blockers are not first line in acutely intoxicated patients. They may be used only if the patient is not acutely intoxicated, right? I'm not saying never use, but when the patient is acutely intoxicated, according to American College of Cardiology guidelines, do not use beta blockers when patient is in that state. Then next, sublingual nifedipine, not recommended due to increased mortality in patients with coronary artery disease. So calcium channel blockers like nifedipine should not be used in these patients. So what are the take-home patients here? The take-home points. Cocaine, chest pain plus intoxication, use benzodiazepines plus nitrates. Nifedipine is not first line. Beta blockers may be used only when not acutely intoxicated. Valence syndrome is LAD ischemic risk, no stress testing. All right, then acute, what is the super formula? Acute cocaine intoxication with sympathetic overdrive, hypertension, tachycardia, alpha adrenergic mediated coronary vasospasm, ECG evidence of valence pattern, contraindication to beta blockers due to risk of unopposed alpha agonism. So first line therapy with intravenous benzodiazepine and nitroglycerin. And what is the SUPERPoint? SUPERPoint here is what is the most important point you learn from this question. In acutely intoxicated patients with cocaine associated chest pain, first line treatment is benzodiazepines with or without nitroglycerin. Beta blockers are reserved only for patients who are not acutely intoxicated. So do not give beta blockers in acutely intoxicated patient. Give benzodiazepines and nitrates. All right, folks, let us stop because it is already more than an hour, and our master class continues every week. So please join our master class every week, and we discuss very up to date information from cardiology to microbiology to every subject you can face in your examination. And SUPERPoints is about learning the most important points. Obviously, in 1 year, you cannot study all the textbooks from embryology to pediatrics, right? You need to learn SUPERPoints. That those are like high yield points, which will give you super score in your examination. And I will see you in the next class. All the best, and you are the heroes.